Okay, here we go. So I'm going to share my screen. I won't be able to see the chat, I don't think, while I'm presenting, but if you guys have questions while we are going, put them in the chat. We can get to them at the end. And then, yeah, if you have any comments or anything like that throughout the presentation, just feel free to put them in the chat. So let me play this PowerPoint. Can you guys see that okay? If someone could come off mute and tell me.
Yes.
Okay, perfect. All right, so like I said, my name is Maureen Diesman. I'm a psychiatric nurse practitioner, and I work out of the Aldie office in Aldie, Virginia. We're just west of the Dulles Airport, if you've ever been through there. So I'm part of Columbia Associates, and I'm also one of the medical resource directors in the DMV. So we will get started here. We're going to be talking about anxiety and benzos, benzotapers. So one thing to just kind of start off with, we're going to talk about the symptoms of anxiety. A lot of you are prescribers. I'm sure some of you are therapists. Perhaps we have other members of TCN here today too. So I'm going to try to make this accessible for everyone in the best way I can, but please do put questions in the chat. Some of this will be a review for some of you, I'm sure. So symptoms of anxiety, we know there is definitely feelings of nervousness, restlessness, muscle tension. A lot of times with panic attacks, very severe anxiety, people will feel a sense of impending doom or impending danger. Sometimes they'll describe it as feeling like they're going to die and they have no clue why, but they just feel like they're going to die. Some of the physiologic symptoms, we'll see an increase in heart rate, increase in respiratory rate or rapid breathing, and then diaphoresis, which is sweating. And then this is just a continuation. So then we'll see trembling sometimes. People will feel easily fatigued, especially if they have anxiety a lot of times.
Sorry to interrupt. We can only see the first slide. I think we're not seeing the slideshow view. We're only seeing like just the first one now.
Okay. Thank you for telling me that.
Yeah.
This happened yesterday too. Let me do this instead. Now, can you see the symptoms of anxiety, or is it still the title slide?
Yeah, we can see.
Okay, good, perfect. I won't go through all of these again because we just talked about them, but thank you for the call out. You couldn't see the slide, so this is just what we talked about written down. And then to move on, so some trembling, people feel easily fatigued, especially if they have anxiety a lot of the time. We'll see difficulty with concentration. I will say this is important when people come to you. A lot of times when people have difficulty concentrating, they'll automatically think they have ADHD or they need to be evaluated for ADHD. But it's good to know that this is also a symptom of anxiety because, of course, we screen everybody for everything when they come in during the initial visit, but good to keep that in mind. We can also see a difficulty in sleeping, some stomach upset, headaches, difficulty controlling the worry, and then avoidance of things that make people worried. So the neurobiological causes of anxiety, this would be more of those physiologic symptoms. So what we're seeing is an abnormal stress response from the autonomic nervous system. We can see an increase in heart rate and blood pressure, sweating, tremors, increase in respiratory rate, which is breathing. And there's something called the HPA axis that modulates all of this, the hypothalamic pituitary adrenal axis, hypothalamic pituitary in your brain, and then the adrenals on top of your kidneys. Those all modulate things like cortisol and that kind of thing. And that really is in control of your fight or flight response. A lot of people add freeze into that, fight, flight, or freeze. And the goal of our treatment with anxiety, whether we're talking therapy only, meds only, or a combination is really best. We're looking to inhibit or decrease this fight, flight, freeze response. And we're hoping that the neurotransmitters can help suppress the HPA axis to the point where we can have more of the serotonin and GABA that we're looking for. And we're going to talk about GABA more in a minute, if that's a new term. So when we think about medication management and NPs, so I do meds all day, we're thinking about SSRIs. So these are our first line for anxiety, also for depression. And it does take, unfortunately, 3 to 4 weeks to start seeing an effect. It's important to consider that because if somebody is really anxious in the moment, it can feel hopeless to know that you'll have to wait a couple weeks. But that being said, we have, and we'll talk about this more later, we have some as needed medications we can use that are benzos or are not benzos to manage those couple weeks, which is super helpful. But we know that our SSRIs combined with therapy is really the gold standard. And we're very lucky at TCN that we have therapists and prescribers in-house. So it's very easy to marry the two and make sure that our patients have that wraparound care. So first-line agents for SSRIs would be sertraline or Zoloft, Lexapro, which is escitalopram, Paxil, which is paroxetine. There's also Celexa, which is citalopram, and then fluoxetine, which is Prozac. So it's good to know that fluoxetine can be very helpful for anxiety, but it does usually make the anxiety worse in people for the first week or so. It usually gets better from there, but not always. I actually personally love Prozac for anxiety. However, I will say that some people are scared of the the thought of it getting worse, which is totally fair. And you have to think about the patient holistically. Is this someone who can manage that, or are they barely getting to work, barely taking care of their kids, whatever it is, because the anxiety is so bad, maybe we can't make it worse for a week. Something else, which is perfectly fine. And I think I said this, but these are the same meds we'd use for depression. So if someone has both, that can be helpful. Second line agents, if the SSRIs are not effective, we can try an SNRI. So that would be like venlafaxine, which is Effexor, Cymbalta, which is duloxetine. There's some other ones too. Those are really the only two I use for anxiety. But it's good to know that SNRIs, like fluoxetine, Prozac, they can be a bit activating at the beginning. Again, that sometimes gets better, sometimes it doesn't. So we might go from an SSRI to an SNRI to, there's something else, we'll talk about this later, Buspar, that might be an option. Depends how you practice and what you've seen success with. But it is good to know that the SNRIs can be a little bit activating because SSRIs, we're talking serotonin reuptake inhibitors, where an SNRI is a serotonin norepinephrine reuptake inhibitor. So it's the norepinephrine piece that can really kind of heighten that anxiety right there at the beginning. And again, there are people it works great for. I had a patient who, he's 17 now, but he was 16 when he came to me and we were getting his meds sorted. And I had tried him on sertraline and I think another SSRI. And then I ended up putting him on his Effexor. And I thought, I don't know how this is going to work with the anxiety, but it ended up being great. And I mean, I see him every 3 months now. He's doing great. So he's just cruising on his Effexor and it's going really well. It's also good to consider that we can augment these SSRIs, SNRIs, which both take 3 to 4 weeks to start working. You can see some of the side effects of SNRIs pretty quickly, but that's just anecdotal to my experience. It can be hard when the side effects show up before the good results show up. It can be hard to keep patients bought into medications when that happens, but you can augment with things that aren't benzos, that are anxiolytics. Anxiolytic is just a fancy word for anti-anxiety medication. So short term, especially in those first 2 weeks of treatment when you're waiting for the SSRI or SNRI to kick in to see a real effect, we can use things for the severe anxiety panic. And even for people who aren't having panic attacks, which is really like one of the most severe forms of anxiety, even for people who aren't having those, just for comfort, you can have like hydroxyzine. We'll talk about this later. There's some other medications you can use too, but it can be really helpful, again, with patient buy-in to give people a little something and say, hey, it's going to take a couple weeks for this Zoloft to work, this sertraline to work, but I can give you something else that you can take as needed. You can see how that goes. One thing I do want to mention, there is a black box warning for increased suicidality in people under 24 and under, who use any antidepressant. This goes for not just the SSRIs and SNRIs, but like actually Buspar falls under that, Wellbutrin too. Those are kind of oddball antidepressants, but they all fall under this black box warning. And I will say this, when you explain this to parents, it's important to understand where the black box came from. So as clinicians, a black box warning, we take it seriously. We have to educate the patient 100%. It needs to be talked about. It needs to be talked about with especially the person that's taking the medication. If you start to notice these feelings, of course, I want to know, go to the hospital, all those good things, the safety planning that we always do. It's important to know that people who are under 25 have higher suicide rates. That's a very broad statement, but have higher suicide rates than people over 25. And there's specific breakdowns within age groups. I don't have all the statistics, but it's important to know that like teenagers and young adults especially have higher rates of suicidality than the rest of the population. So consider that. Consider, is it that this population is just more at risk, or is it that the antidepressant is causing this? Another thing to consider is that antidepressants are usually only given to people who have anxiety or depression, which makes you, if you have anxiety or depression, you're more at risk for suicide, especially depression. So is it that these medications cause people to have increased suicidality, or is it that these patients are more at risk of having increased suicidality and they're also taking these medications? So the causality there is pretty unclear. Again, people need to be warned about this. Huge liability thing. You have to talk about it. But I also want you to understand where the black box warning comes from and really look at it critically. If you're interested in this, even read about it on your own, because I think parents can find comfort in, parents especially, when you explain it this way. Like, yes, it's possible that antidepressants cause suicidality, but it's also possible that people who are going to have suicidality are taking antidepressants. So it's important to hash that out. It's also important to say not everybody who takes an SSRI is going to have suicidality. That is absolutely not the case. It's not even common, but it's important to talk about. Okay, there we go. So next, we're going to talk about some non-benzo anxiolytics. So Buspar, you have to take it twice a day. I've had a lot of PCPs. People come to me, their PCP put them on Buspar once a day. It won't work. You have to take it twice a day. It has to do with the half-life of Buspar. It's shorter than that of the SSRIs and SNRIs, which usually stay in your system for 3 to 5 days. The half-life is like 3 to 5 days. Prozac's, weirdly, is 2 weeks. But besides that, they're usually about 3 to 5 days. Buspar's is much, much shorter. It's less than 24 hours. So if you're thinking about a medication needing to build up over weeks in your system, which Buspar does, but it's coming in and out of your system pretty quickly, you not only have to take it every day, but you have to take it twice a day. It will not work as needed. Don't try it as needed because it doesn't work. In the Stahl pharmacology books, if you're a prescriber, you know Stahl, it's in there too. It doesn't work as needed. Hydroxyzine is technically an antihistamine, but it works very mediocre as an antihistamine, but it works well as needed off-label for anxiety. Something to note about hydroxyzine, there's 2 kinds of it on the market. There's hydroxyzine HCl, which is more known for having the sleepiness that antihistamines are known for. So like Benadryl is another antihistamine. I give hydroxyzine HCl to people who, like, the perfect person for it is someone who says, sometimes, but not every night, I have a hard time going to sleep because my anxious thoughts keep me up, or I can't turn my brain off. People use that phrase, I can't turn my brain off. Hydroxyzine, it's not a sleep problem, it's an anxiety problem, right? And the anxiety is getting in the way of the sleep. Hydroxyzine HCl is perfect for that. It comes in 10 milligrams, which is the lowest form. That's often what we use in kids. In adults, at least anecdotally in my experience, they need about 25 milligrams, but that's fine. I have one adult that takes 10, but that's fine. The other form of it is hydroxyzine pamoate. So hydroxyzine pamoate only comes in capsules, and the lowest dose is 25, unfortunately. But still, you can use that. Hydroxyzine pamoate is not as known for making people sleepy. So I think of HCl, it has an L in it. Sleepy has an L in it. That's how I remember it. But come up with whatever you want to remember it if that's news to you. But it is important because we want to know where this as needed anxiety is coming from, or where the situational anxiety is coming from. Is it when I'm trying to go to sleep, or is it every time I have to drive on 66 in the DMV? That makes me stressed. It's a big highway that has a lot of traffic. All of those things, I'm sure whatever market you're in, you have your version of 66. But if it's that, okay, I don't want to give you hydroxyzine HCl because then it might make you sleepy. I don't need you to be sleepy when you're operating a vehicle, right? But hydroxyzine pamoate might be more helpful because it can help with the anti-anxiety effect, but not make you as sleepy. That being said, I do always tell people the first time you try it, be at home, be in for the night. For adults, I tell them don't be consuming alcohol that evening just because that can make you sleepy. You won't know what's what or what's causing what. It's good for people to be at home, not operating machinery. I always have the caveat on with machinery of you don't have anything else you're responsible for. So, for example, if you're watching your infant, you're not operating heavy machinery, but you need to be engaged and paying attention, right? So, same kind of thought process. Think about where you're going to be the first time you take it to see if it makes you sleepy and to see how sleepy it might make you. And some people have no sleepiness side effects with the HCl. Some people have a little bit with the pamoate, but generally speaking, HCl will make people sleepy and pamoate won't. So consider that when you are prescribing. The HCl, you can break they're usually tablets and you can break them in half, but the pamoate's only capsules, so you can't break them. Other things, so beta blockers, propranolol is a good one. Propranolol, you probably know of it as a heart medication, which it absolutely is. It can lower blood pressure, lower heart rate. Very useful for a lot of things. I love beta blockers. I love propranolol for people who get those physiologic symptoms of anxiety. So people who have the increased heart rate, the increased respiratory rate, the sweating, people whose anxiety manifests in those really physical ways. I love propranolol for that. A little clinical pearl about propranolol. It's contraindicated if you have breathing issues, like asthma kind of issues. It can increase bronchoconstriction, so that makes it harder to breathe. So good to know that. And of course, we would have gathered that information in our history taking, but good to mention. And then for kids, we really like, these are both alpha agonists, clonidine and guanfacine. Hydroxyzine, again, is an antihistamine, but clonidine and guanfacine are alpha agonists, and they can be really helpful. They are off-label, but can be really helpful for anxiety in kids. We usually give them at night. They usually make you sleepy. There's an extended release version of guanfacine called Intuitive that also usually makes you sleepy, so take that at night, even though it's extended release. And I will say too, sometimes you'll see guanfacine specifically, but clonidine as well sometimes can be helpful for the hyperactive symptoms of ADHD. So sometimes you'll see that on people's med lists at night, especially little kids, that can be helpful. And then important to remember that with these medications, we're not going to make the anxiety go away probably, but our goal is to reduce it or to make it manageable. I like to remind people that no matter how good the medication is, it's not going to take away your life stressors. If work is really hard or family stuff is really hard or financial issues, whatever it is, like Zoloft's not going to take that away. The goal is that it helps you manage those things better. And then, of course, that's where therapy is key, right? Learning to manage things better and helping with those coping skills, all those kinds of things. All right. So now we're going to talk a little bit about benzos. So benzos potentiate GABA. Maureen, what does that mean? So GABA is a neurotransmitter and potentiate just means increase. So benzodiazepines increase the activity of GABA in your brain. GABA is the calm down neurotransmitter. And by doing that, it decreases anxiety. This is not a one-to-one analogy, but benzos are the closest thing we have to alcohol in a pill. Alcohol also works on GABA. And so when we think of alcohol as a central nervous system depressant, we'll talk about that a little bit more when we talk about the withdrawal, but benzos and alcohol work on the same receptors. They work on GABA. So definitely don't take them together. Definitely don't do that. But it's important to know because it can help you understand how powerful benzos can be and how addictive they can be. We know, for example, that if someone came to you, someone walked into your office and they said, every time I get nervous, I take a shot of vodka. And calms me down, so it works. So I'm just going to keep doing that. You would probably take issue with that, right? So benzos are not necessarily, consuming alcohol, but you are working on similar receptors. So when people come in and say, well, every time I get nervous, I just take a Klonopin. It's like, okay, there's probably more to that story. Is your baseline anxiety managed well? Probably not. Are you in therapy? Probably not. Can we work on those two things? And it's also good to consider that benzos, especially alprazolam, which is Xanax, and lorazepam, which is Ativan, they work really quickly. So consider this: if you had really significant anxiety and you knew that in your bag you have a little bottle of pills, and as soon as you take one of those pills, within a couple of minutes, you're going to feel better. It would be really hard not to use them all the time. Knowing that the relief is right there within your grasp, knowing that you have a prescription for it, it's legal, right? This is prescribed to me, but these medications are very powerful and they should be treated as such and should be dispensed as such with a lot of care and thought. They are really only intended for short-term use and at the lowest possible dose that is effective. So we do not want to be giving people, every person who comes in that says I have anxiety, I am not giving them a whole bottle of Ativan, which is lorazepam. Just, if you ever need it, just hold on to it. We're not doing that. I honestly only start benzos as needed, never scheduled. And I only start them for people with panic attacks. And I'll give people a little bit. I'll say, how often do you have a panic attack? They tell me once a month. I say, great, I'll give you 10 pills. They probably expire within a year. Most medications do. So if in a year you still have 10 pills, we'll safely dispense at the station or however you do it in your area, and I'll give you 10 more. But I'm not giving people tons of these benzos because it's just dangerous. And it's, quite frankly, it's so tempting. Consider too, like, I've met many people with alcohol use disorders, but I've never met someone who set out to start drinking alcohol in order to develop an alcohol use disorder, right? Like, people don't want to do that. It happens though, and we know it happens. And it's the same with benzos. People don't set out wanting to become addicted to them, but it's very easy to get addicted to them, which is why we as the prescribers have to be very judicious in how we give them out. But then also the therapists, if you have a patient telling you, oh, well, I don't need your coping skills because I just use my Xanax. If they see a TCN prescriber for meds, the TCN prescriber probably wants to know that they're using the Xanax all the time and not using coping skills. Like, that's a problem, right? So collaboration can be super, super helpful there, especially because sometimes the therapists, you guys spend more time with the patient than the prescriber usually does. You guys also have deeper relationships. They'll open up to you more. Usually that kind of thing. I really, really appreciate when therapists message me and say, hey, I don't know if so-and-so mentioned, but, and almost never so-and-so has not mentioned what the therapist is telling me. So it's very helpful, very, very helpful when the therapists let us know those things, because they can tell us like, oh, I thought this person was using this benzo responsibly, but maybe they're not. Or maybe they have a new life stressor and they're really leaning on this prescription much, much more than I intended them to. And I need to have a conversation with them about that. So that can be really helpful. Also important to note that, so some of the benzos there's more than the 4 listed on the slide, but these are the 4 that are used the most. There's one called temazepam. People use it for sleep, but there's another one, oxymazepam. We don't use it a lot. Doesn't matter. So there's longer half-life ones, which are clonazepam, which is Klonopin, and then diazepam, which is Valium. Those last longer. If I'm remembering correctly, Valium lasts the longest. I think it lasts like 10 to 12 hours, the half-life is. It's pretty long. And so you need less frequent dosing with those because the medication lasts longer. Shorter half-life, Xanax and Ativan, alprazolam and lorazepam, you need much more frequent dosing, and they come into your system quickly and leave your system quickly. And so that up and down is where we see more of an addiction piece coming in. You can get addicted to Valium and Klonopin for sure. You definitely can. But it's more likely with the Xanax and the Ativan. If I'm remembering correctly, Xanax is shorter than lorazepam, lorazepam is shorter than clonazepam, and then clonazepam is shorter than diazepam. Pretty sure that's how it goes. So Xanax, like I don't think I've ever given out Xanax. Maybe a couple people, like severe panic attacks. But like in my experience, how I practice, I usually would do the Klonopin for panic attacks. If people tell me it takes too long to kick in, then we can talk about an Ativan or a Xanax, but not usually if we can avoid it. So then tapering of benzo. So this is really important. One thing, we haven't really talked about this yet. So there are really serious side effects of benzos being discontinued abruptly. So especially if someone has been taking the medication for a very long time, and if they've been taking it every day or more than once a day. I have a very sweet 79-year-old patient. I actually saw her yesterday who has been on Klonopin 3 times a day for 40 years. I tried to taper her off of it. Medically, it was just not going to happen. She has some other medical complications. It wasn't happening. Not to say I won't try again in the future when things settle down medically, but when people have been on benzos for 40 years, 3 times a day, you have to think about it as like their central nervous system has been depressed to a certain point for 40 years. It's a very long time. And you're then asking the body to adapt to having less of that depression, which, as we'll talk about later, can lead to all of these side effects. 40 years, 3 times a day is a very, very long time to be on benzos. And another kid come to me, not a kid, he was 28, but he had been started on Klonopin actually as well. He was up to 6 milligrams a day, which is an absurd amount of Klonopin. No one should be on that much Klonopin every day. Interestingly, the psychiatrist at his undergrad university, he went in for anxiety. The person gave him all of this Klonopin. He hadn't been on it for long. By the time he had come to me, it had been like 6 years, I think. So 6 years is a long time, but it's not forever. And we very slowly, I want to say it took us 6 months it might have taken us 9 months or a year to get him off of all of that Klonopin. And he was drinking alcohol, which is another kind of mitigating factor, but it takes a long time to get people off benzos. If someone's been on it for 6 months, 3 months, you can get them off it fairly quickly, but it usually does take a while. And it's important to manage your expectations, manage the patient's expectations. There's family involved, other loved ones, manage everybody's expectations. To do this safely, we have to take our time. So, and I kind of talked about this first bullet point, but if you think about the addiction piece, addiction with anything, over time, you need more of the same to achieve the same result. So if someone, and again, alcohol's like the best analogy, if someone drinks 1 beer a day, every day for 30 days, on day 1, they'll get X feeling from drinking 1 beer. On day 30, they're not going to have as much of that feeling that they had on day 1 because their body's becoming tolerant to the alcohol. The same thing happens with benzos. So because people become tolerant to it, they'll then need more and more and more. But you're just digging yourself deeper into the hole by doing that and prescribing that way. But again, this is why we do not plan to use them daily. We plan to use them as needed, and they absolutely have a time and a place as needed. But daily is almost never. The one caveat would be some sort, like if you were doing alcohol withdrawal, which shouldn't be done outpatient, should be done inpatient, which is different. But really, we shouldn't be giving these daily, or catatonia, which again, probably wouldn't see outpatient. But regardless, we want to make sure that if people have a history of substance use, any kind of substance use, I would also put gambling on there, any kind of addiction history, then we want to be very careful, especially in those patients, because we may be risking their sobriety by introducing these medications. Again, if you have those pathways just very much so ingrained in your mind of addiction, it's very, very hard when someone gives you a new addictive substance to not go down those same paths. And we don't want to undo any good work that likely our therapy colleagues have done with our patients. We don't want to undo any of that. We don't want to put the patient in a bad situation. So consider that. Benzos can cause respiratory depression. So if someone's taking any kind of opiate, methadone, Suboxone would be a good one. Even consider if someone has a benzo prescription and then they're also getting, I have a patient that I see her for Spravato, but she had foot surgery and she gets benzos. So I told her, like, you really have to be careful because for her foot surgery, they gave her, I think they gave her Vicodin, I don't remember, but any kind of opioid can decrease your respirations as well. If you top a benzo on top of that, decrease the respirations too much, you can eventually stop breathing and pass away. So you have to be really careful about that kind of thing. And it's important to know if you are trying to have these discussions with people and you want to talk to perhaps they see like a Suboxone clinic, methadone clinic, and you want to have a chat with those prescribers, that's definitely your right. You're absolutely welcome to do that. If you want to get a urine tox screen, absolutely welcome to do that. If people are fighting you on that, that's a red flag. You want to be able to have those conversations. And then any other sedating medications. So I would think of like Ambien or Trazodone, those are sleep medications, anything like that, or sedating substances. Interestingly, gabapentin taken with a lot of things that are not sedating, but plus gabapentin makes them sedating. So gabapentin on its own, unless you take a lot, isn't usually sedating. And then like phentermine, which people use for weight loss, if you take them together, they're sedating. So if gabapentin is on the list too, I would be wary. Just be wary of that. And then, of course, heavy alcohol use. So if someone's using a lot of using a lot of alcohol, and you're considering giving them a benzo, I would absolutely try hydroxyzine first, propranolol if it's appropriate. I would try everything else first, really try to get their baseline anxiety in a much better place with your SSRI, your BSPAR, whatever you're doing, make sure they're in therapy, to really make sure of that, because we don't want people using alcohol and benzos at the same time. But then also consider, I don't want to tell someone, we'll just stop using alcohol. Again, if you've been using alcohol daily for X amount of years, if you stopped, you'd probably get withdrawal symptoms. So it's a delicate balance, and it's a delicate conversation. Then we talk about children and elderly. I don't think I ever have given a benzo to someone under 18. You would need a really, really good reason. You would just need a really good reason. And then in the elderly, we know that long-term benzo use can lead to memory impairment. Actually, my sweet 79-year-old woman, her neurologist and I agree that her memory is starting to go, and it's probably because of the benzo use. And we'll talk about that a little bit later. But you also want to consider that people who are elderly are often on a lot of medications. So is there any potential interaction that's going to make sedation worse? And then also, are they going to be a fall risk if we give them a medication that can be sedating, even if they're on nothing else? When you get older, your liver and kidneys, your liver really more so than the kidneys, doesn't always metabolize medications the same way as it once did when you were younger. And that can mean less efficient metabolization, which can mean you can have more side effects, more effects from the medication overall. So just being super careful in your elderly patients. If you want to give a benzo, like if you were going to, I would give them something that was long acting, like Klonopin. And then I would do the smallest dose. And if it's a tablet, even tell them to cut it in half. See if a half works. If half doesn't work, then take a whole one. But just try with the lowest effective dose that you can. So we have some macros. I can put these in the chat at the end, so it'd be easier for you to copy into your Valent. We have two macros. There's one on the next slide too. These are just risks for benzos. So we talked about risk of abuse, dependence, withdrawal, and seizures. So we actually didn't talk about seizures too much. One of the big risks with alcohol withdrawal, which again, that should be done in patient, benzo withdrawal can be seizures. So if you think about your central nervous system as a spring, if you put a weight on top of the spring, it will compress the spring. And if you compress the spring for a long time, and then all of a sudden you take the weight off, there's a rebound, right? The spring would spring up and it would go, higher than it would like jump off the table per se. So that can happen to your central nervous system. And when that happens, we can see seizures. It's very, very dangerous. It is very important to consider that when people have seizures, if they lose consciousness, they can die. So being on a benzo, if they become addicted to it, if they are physiologically dependent on it and then you abruptly stop it, they can have seizures, they can die. Also consider if you have a seizure when you're driving, something like that. Have a seizure and you fall down, hit your head, lots of things can happen. So we want to be very, very careful about that. Again, inpatient can be very valuable for this. Seizures can happen. And then also consider too, if someone has a seizure history, then they would be just more likely to be at risk for a seizure, or if they're on something like Wellbutrin, which can lower the seizure threshold, then you would want to be extra, extra careful with your benzos, things like that. And then, so you can have a fatal overdose, again, so if you took too much of a benzo, or if you mixed a benzo with alcohol, too much of it together can cause respiratory depression, people can pass away. That would be an overdose. There can be sedation, don't mix with alcohol, or other things that can cause sedation or respiratory depression. So that would be opiates. Some other illicit substances. Don't drive or operate heavy machinery, or don't do anything that you need to have good reflexes and be on alert for. Do not divert the medication. Keep the medication secure. Controlled substance policy. You probably have one for your market. I think there's actually a general TCN one. There is a risk for Alzheimer's dementia with long-term use of benzos, and then the FDA has only approved benzos for short-term use. And on the note of keeping medications secure, I always tell my patients, and this isn't just benzos, but if I put them on any kind of stimulant or any controlled medication, I'll always tell people, if you live out in the country, this doesn't necessarily apply to you, but if you live in a densely populated area, I would shred all of the like the informational packet that the pharmacy gives you. So like put the medicine in a bag and then they'll staple that packet. The packet usually has information about your address and then what kind of medication it is. And so I always shred those, and I tell people I would shred it because you just never know, like if it flows out of your recycling bin and someone knows, okay, at this address they have this medication. You just don't ever want that to fall into the wrong hands. You don't want people knowing that you have those medications in your house. You don't want to advertise that you have those medications in your house. And again, that really goes for any controlled substance, just to keep it quiet if you can. And then our next macro is for the long-term use of benzos. And we really talked about all of this. Rebound anxiety, which comes from the central nervous system being suppressed and then no longer being suppressed, and then worsen outcomes for PTSD is kind of in the same vein of that rebound anxiety. Yeah, and then we've really talked about the rest, but this is just helpful for just to have in your valent macros, so you can just pop them into your notes whenever you need to. And then withdrawal symptoms. So if you're really interested in this, there's a scale they use for alcohol withdrawal. Again, that would be done inpatient, but it's called a CIWA, C-I-W-A. So you would often see with withdrawal from benzos, similar to alcohol withdrawal, diaphoresis, which is sweating, pinpoint pupils, increased heart rate, nausea, restlessness, tremors, confusion, and seizures. The confusion is especially concerning, and abrupt discontinuation can be life-threatening. We talked about that a lot. So that's the seizures and everything that can come with having a seizure. And then signs of misuse. So misuse doesn't always mean abuse. And like I touched on earlier, I've never met someone addicted to something that set out to become addicted. It happens. People might not realize it's happening, but it is important to consider if someone is asking for early refills. It seems like they're running out of their medicines early. They come into the office or they're on telehealth appearing sedated. You see them on telehealth, but they won't turn their camera on, that kind of thing. Or if they have a history of substance use, just start the conversation. How often are you using the medication? This is what we agreed on for the use of the medication. This is how we're going to proceed in the future. Do you have any concerns about that? Just start the conversation and make sure that if we can catch it early. That way we can get the person help before it becomes a large problem. And then tapering, it depends on the medication, exactly what doses you are going to do. but it really ends up depending on how long the person's been on the medication, how much they're on, and how often they take it. So again, like you've been on Klonopin 3 times a day for 40 years, it's going to take a really long time to taper somebody off of that. You've been on Ativan once a day for a month, it's not going to take that long to taper off of it. But we want to make sure that the patient's on the same page, the loved ones as well, manage expectations. This is going to take a minute. It does not happen overnight. Doing this overnight can be very, very risky, lots of side effects, potential for death, huge, huge risk. And then really it comes down to your clinical judgment. There's for every patient that you want to taper off benzos, there's multiple ways to do it. One thing, I don't know if it's mentioned in this presentation, it might be on the next slide, but sometimes if someone's on a shorter acting benzo like Xanax, you can switch them. Instead of taking Xanax 3 times a day, you can switch them to taking like Klonopin twice a day. It's a little longer acting. And there's a lot of nuance to that, but sometimes you can like get the dose equivalent and then you can put them on a longer acting benzo, and that can be helpful. Again, that's it's going to be very unique depending on the person, their history, how long they've been on it, all of that, what medication they're on, other medical comorbidities, all of those things. But you can consider doing that too. The longer half-life can help with the psychological part of, the medication comes on and then it leaves and then I need more. It can help with that because instead of going up and down throughout the day, you're a little bit more steady throughout the day. So that can be helpful. And when you are doing a taper, you can see insomnia, rebound anxiety, those kinds of things. And again, that's the central nervous system really being depressed and then taking that weight off of it. And then we see this rebound. You can imagine like an increase in anxiety probably isn't going to help you sleep. So then it makes sense the insomnia would come with that. So when we talk about tapering examples, so fast tapers, the fastest but safest way you can do a taper when someone's showing signs of misuse, that's good. We don't want to drag it out too long. We do need to keep it safe. And then if someone's having any signs of withdrawal, I would actually consider whether or not they need to be hospitalized. It'll always be in the back of my mind, but consider that. Consider if you need to pause the taper or go slower than you're going. That could be the case. And you're looking for things like the insomnia, the anxiety, that kind of thing. Hydroxyzine's not nearly as powerful as a benzo, but I do like to give people hydroxyzine as well and say, like, if you're having a lot of this anxiety, try and take a hydroxyzine instead. And like if we're tapering somebody off and they're really trying to stick to the plan that we've set, as long as they're not having these significant withdrawal symptoms, try to take a hydroxyzine or propranolol if it's appropriate and see if that helps, see if that can work. And people who miss their appointments a lot or frequently ask for refills, we want to have a conversation about taper or about if it's appropriate for them to consider on a benzo, continue on a benzo. It might not be. I would really trust your gut on that one and use your clinical judgment making. It's also helpful to consult whether you're in a state with a supervising physician, if you're an APP, or any provider. Consulting with another provider, often saying it out loud and someone else hearing it just from an unbiased standpoint. They can say, yeah, that sounds fishy, or no, I don't think that sounds fishy. And they can help you as well. I've done that in the past. It's helpful. And then, yeah, so perfect balance doesn't exist. Too conservative and we're prolonging the problem. Too liberal and we can have these significant side effects. We can have dangerous side effects, that kind of thing. And really the goal is to work with the patient and just try to provide harm reduction strategies. Just do our best. And I would consider too, like, you're not in a silo at TCN. We have a lot of collaboration. You are not alone. You can ask people for help. You can collaborate with therapists as well. Even if you're not talking about prescriptions, you can collaborate with a therapist, supervising your colleagues, and really just don't think you're doing a bad job if it takes a long time. Sometimes it just does, and everybody's different. So everybody metabolizes medications different ways. And then for the documentation piece, so we want to document a taper plan really well if we can. I like to put week 1, week 2, week 3, and then I usually like to write on a sticky note, and whatever I write in the chart, I'll also put on a sticky note and give it to the patient. Sometimes they'll take a picture of it with their phone just so they can keep the plan, and a visual can be helpful versus they walk out of the office and they say, wait, what did you tell me to do? So that can be really helpful, writing it down. Or if you use the secure messaging on Valent, I don't think all the markets have that, but use that. You could send them a message too, so they have it there written down. And then just make sure you're doing a risk assessment, rationales for using benzos, and documentation if you're using a lot of them, and checking the PDMP. So just making sure that if they're getting benzos from you, they're only getting them from you. We don't want to be seeing other people's names on the PDMP. We don't want to be seeing other substances on the PDMP that we don't know about. Keep an eye on that. And then, of course, if there's a comorbid history of a substance use disorder, try and collaborate with the people that are prescribing, like if it's a PCP or some sort of addiction specialist doing the Suboxone, or they're going to a methadone clinic for methadone, really trying collaborating and just saying, hey, reaching out and saying, hey, I'm thinking about starting XYZ for this person. I know they see you for methadone. Can you tell me how consistent they've been? Can you tell me if you've ever had issues? Can you tell me if you think it would be safe for them to have 10 Klonopin to take as needed for panic attacks? Do you think that they would divert it? Do you think they would take them all at once? What do you think? It can just be helpful to get other people's opinions, especially if the patient is new to you. I can't think of a time where I had an intake and the person left with benzos. That usually doesn't happen, unless they come to me asking to be tapered off. Maybe that would be the situation, but you don't have to give them out if you're not comfortable with it. If you don't know the person, if you don't trust the person, you do not have to give them medication. We don't want to do more harm than good. And if you're very unsure if harm is going to occur because you don't know this person very well because you just met 60 minutes ago, then that is valid and you don't have to give them benzos right away. And I would seek your clinic director's support if the patient is upset about that. In our office, we have a policy, like we have our refill policy and our substance, like controlled substance use policy. We have it like framed in our lobby. So, I mean, stuff like that can be helpful too. You're getting a lot of that, but yeah, or your MRD can back you up too. And then if we're having any behaviors that we're not happy with, so we need to really understand what's going on. Why is this behavior present? And is it something to do with the taper? Is it not? Sometimes people, like I said, have a hard time understanding the tapering plan. To us, it can seem so simple and it can seem so straightforward and easy, but for people who don't think about meds and talk about meds all day, it can be really challenging. And so that's why I would recommend writing it down. You can do shorter supplies and more frequent visits. So if you'd rather do, we'll give you enough for 2 weeks instead of giving you enough for a month, you can do that. And then, so I mentioned this earlier, but switching from a shorter acting to a longer acting can be helpful. Motivational interviewing for the goals of benzo tapers, motivational interviewing always for anything related to substance use, and especially decreasing use. We're talking about benzo, alcohol, anything like that, marijuana, and limit setting. It is important to outline a plan and really hold your ground, especially if the patient is giving you feedback. And again, if you need to get your clinic director or your MRG to support you, definitely do that. And of course, educating the patient why there are risks and why we have tapers, why we have to make a plan. And of course, you would need to tell them what all the side effects could be and that kind of thing. And you can have them sign a behavior contract if you want to. And then, of course, if there's extreme behaviors or repetitive behaviors, especially after discussion, people can get discharged from the practice. It happens, it's unfortunate, but it does happen. And then just the last slide here, we have some TCN benzo guidelines and then a VA benzo taper guideline. And I'm going to stop sharing. Okay. I'm going to look in the chat here, and then we have a couple minutes for questions. Let's see. Oh gosh. Okay. Form for attendance. Thank you, Jack. Oh gosh. Yeah, Carlene, I've heard of that too. Carlene put in the chat something about TikTok has been having videos of children struggling with mental illness telling other children that they should kill themselves. That is so frightening. That does happen. There's a lot of untrue information online and a lot of scary information online. Yesterday. Okay, for Joshua, I think you're only supposed to sign it once, but that could be wrong. Jack, I'll let you manage that. And then, okay. Yeah, if we have any other questions, please feel free to unmute, raise your hand, anything. Questions?
I have a quick question. So I can't remember if I read that somewhere or I was talking to a psychiatrist, and the opinion was benzos have been abused, underused, and then like what he said, that the benzos work for about 10% of clients or patients who have anxiety, and that was kind of like they had to monitor first to kind of like see what kind of behavior they're having when they're taking benzos, like whether they're actually developing substance dependency or no, or they have a history of addiction, or just like you mentioned. But there wasn't an objection towards its use as a long-term treatment for a minority of patients who have anxiety. So I just wanted to know what's your take on that.
Yeah, I mean, so the FDA has only approved them for short-term use. So the textbook answer would be that no, you shouldn't use them long-term because that's not what they're approved for. I would say if you're using them indefinitely, you have to have a good reason and you need to document that reason. If you're an APP who has a supervising physician, I would talk to your supervising physician about that. It sounds like this person was a physician. I will say too, people used to give out benzos indefinitely, multiple times a day, indefinitely. That used to happen a lot. And so sometimes providers who have been doing this for a very long time are very comfortable doing that. So that could be the situation too. But I would just say if you are going to do that, you need to have a very good reason and you need to be clearly documenting, which perhaps this physician was doing. Maybe they did have a very good reason and they were documenting it well.
Okay. So I'm a therapist. So one of my clients was complaining that the prescribers are, quote, very stingy when they're like, because he doesn't have a behavior of like abuse or anything when it comes to medication, at least from what he has been sharing in the session. So and his defense was like, they should know me by now that I'm not attempting to abuse it or misuse it in any way. I just need it to be able to sleep. And like, so what would your response be to a patient who kind of like expresses that, and so that you can kind of like depersonalize it and just kind of like give him some information about like why do they have to do that?
Yeah, I mean, I have a lot of thoughts on that scenario. One, I don't know the patient, so I can only give some kind of peripheral advice. But one thing I would say is if someone is saying, I don't understand why they won't give this to me and really insisting on it, that's a red flag for me. If a patient, like, especially if they've never been on it before, if they for some reason are just coming into my office saying, I really need Ativan, but they've never had a prescription for it, huge red flag. I am stingy with benzos. That is a fair word to use. And I don't see anything wrong with that based on the FDA guidelines, based on the way that we practice at TCN. Like, you should be stingy with them. You should not be giving them out to everybody that walks in the door because it's really dangerous. And like I was saying earlier, there's a potential for addiction. People aren't like that client you're talking about. I'm sure he's not planning to get addicted to whatever benzo he's wanting. But if you don't treat these benzos as serious medications, that's where people end up getting addicted to them.
Yeah. All right. Thank you.
Yeah. What else? What other questions? Experiences people have had with benzos? Oh, here we go. Is there a psychological reason why anxiety is worse in the morning just after waking up? That's going to depend on the person, would be my response. So, I mean, it depends what their anxiety stems from. It's not true for everybody. Some people, it's worse when they wake up. I have a patient like that. A lot of people, it's not. But, oh, a physiological reason? Okay, I see what you're saying. Not that I can think of. I would think of what makes this person anxious. If they get very anxious about their job, or if they have to drive to work, get anxious driving. It could be just that when they wake up, they then have to engage in the thing that makes them anxious. So that would be like a trigger avoidance thing. But a physiological reason, no. If you're thinking of like, as the central nervous system is becoming more active for the day, could it then become overactive or something like that? Not that I'm aware of. It's an interesting question, though. Anything else? You're welcome. Feel free to come off mute. I can hang around for a few minutes, but thank you everybody for coming. I really appreciate it. Definitely make sure you fill out the form, unless you filled it out yesterday. And thank you for coming. I hope you guys have a great day.
Thank you, Maureen. That was wonderful.
You're welcome.